Hi everyone. Oh, they recorded. Hi everyone. My name's Chinoy. My legal name is Shiqian Lee. I'm one of the interventional pulmonologists here. I'll be talking about lung nodules, kind of different topics to talk about, or different modalities and different ways about going about diagnosing and then management for lung nodules. I think the cool, fun part is like the new tools that we have to biopsy a lung nodule, which I'll get into kind of towards the second half of the talk. So. I have a lot of slides. I will try to go through them as quickly as possible. Start with a quick case presentation, kind of sets the mood for what we want to accomplish and how we want to go about the case. So 65-year-old male presents to the clinic with a history of smoking with a 30-pack-year history and quit about 10 years ago. It's commonly seen in like Gen Pulm clinic, probably also seen in regular medicine clinic too. He says a recent family friend passed from lung cancer and he was interested in being evaluated for lung cancer. So it's hard to talk about lung nodules without talking a little bit about lung cancer. One of the biggest fears I think patients will have when they hear like a spot on your lungs is, of course, lung cancer. Here are the kind of the stats that we know. Leading cause of cancer-related deaths nationwide. It like beats out colon cancer and breast, and I think the third one I can't remember off the top of my head, but like those three combined, estimated about 238,000 people were diagnosed with lung cancer back in 2023. My slides are a little outdated. And then approximately 130,000 people died from lung cancer in America about annually. But the fun thing or the good thing is that as our decades have been going through, as we've been progressing in medicine, we've had more and more treatments available, and including like targeted therapy, immunotherapy. So I think this next slide is a little bit depressing, but this is the Kaplan-Meier curve for lung cancer. The one on the left is for non-small cell lung cancer, and the one on the right is for small cell lung cancer. And so small cell lung cancer diagnoses tend to do worse than non-small cell lung cancers. Unfortunately, though, with non-small cell lung cancers, even though they do like slightly better, we tend to diagnose them in the later stages, usually in like stage 3 or 4. Um, oh, our chat. Oh, okay. Um, so yeah, what can we do to try to improve on this stuff? Well, we this was back in 20. Oh man, did I write the year down? 2021? No, earlier than that. I'm sorry. I have it in my notes. I don't have it in my notes. I'm sorry. I think this was about 10 years ago. Sorry. Um, the National Lung Screening uh, Trial was a landmark trial done in New England Journal of Medicine. Of course, this was done a couple of years ago, and I can't remember the exact time. But there's been a slow decline in like smoking and lung cancers over the last like 50 years because after we placed like the warnings for lung cancer risk on like cigarettes, and then just like as like the more and more data came out about how risky or how dangerous it is to smoke, um, people have progressively stopped smoking more and more. But our rates of lung detection have become or were kind of like plateauing, not being able to find lung cancers early, like I mentioned. Like we keep diagnosing them when they've gotten too big or they've reached a critical size, such as like stage 3 or 4. And so this group came out with a study to evaluate early lung cancer screening, because before we would only do it based off of chest X-rays or maybe even like serum markers, which weren't very helpful. And so they looked at, and I'm sure most of you guys know the exact criteria, but they looked at patients with at least a 30-year pack history and between the ages of 55 to 74. And if they had quit smoking, they had to have quit within 15 years. And so they were looking to see if low-dose CT screens could be used as a nice tool for detecting lung cancers early. And so this was a multi-center randomized controlled trial. They enrolled about 54,000 patients. It was over the course of 3 years, the 3 years of which I forget right off the top of my head. And they looked at 645 patients who got low-dose CT scan, and 572 with chest X-rays were detected in lung cancers per 100,000 person years. The main point, though, was that they were able to reduce the rate of death in those that got low-dose CT scans, 247 per 100,000 person years, versus chest X-rays would get a 309 per 100,000 person years. The lot of numbers that I'm kind of like spewing, the short of it is that they were actually showed a 20% reduction in mortality rate when you did low-dose CT scan screening compared to when you did it with a chest X-ray. So with that in mind, a lot of the screening guidelines changed, and such as the USMLE and all those different ones that like recommend screening for lung cancer. And they've changed again, even like instead of being 55 to 74 years, they've expanded the years now to be 50 and 80, and then also reduced the number of PACA histories down to 20. So we're trying to be as aggressive as possible about screening as many people to detect early lung cancers as much as possible. So going back to our patient, he undergoes a low-dose CT scan, and we find a 6 millimeter subsolid nodule kind of here in the left upper lobe. Um, he presents back to clinic and asks, what should we do? So this was created in, okay, so this was created in 2014 after the NSLT low-dose trial came out to standardize what we interpret for these low-dose CT scans. So we were getting these low-dose CT scans, and then across the country, people were, there wasn't a standardized measure to say like, oh, this nodule is high risk, or this nodule deserves this and this. So in 2014, this group called the Lung Rats group came together and they standardized it. So where they made it where if a certain lung nodule was detected, you could then kind of put them into certain categories, and then you would be able to know what the next step to do. And so this was based off of mammographies. So before this Lung Rats group basically came up with the same kind of way they do mammographies into how they categorize the nodules. Um, the left one you may have seen before. It's very busy. It breaks down into like exactly kind of the criteria of the nodule, and then also the sizing of it, and then some characteristics, and then recommends like, and then it puts them into like what category they are, but then also recommends what kind of follow-up they should get. And this is a quick snippet from like a YouTube video I saw that it makes it a little bit easier to understand. So these are categories kind of get the bigger the category, usually those larger the size of the nodule. And so in general, roughly around category 1 to 2, these are kind of benign findings, generally less than 6 millimeters. And I'll go into a little bit more about sizing in a little bit. And then once you get to category 3 and up, this is when you start to hit about 6 millimeters in size and greater, of course. And these can be these should be followed up more closely for fear of whether they're growing, or they could even potentially be biopsy for further diagnosis. So he, based off the patient that in my vignette, off his previous low-dose CT scan, was characterized to be lung RADS 3 based off the size, and was asked to have a repeat low-dose CT scan in 6 months. So this is another follow-up CT scan for him in 6 months. And there was growth from 6 to 10. So this now puts him in a category 4B, which is concerning for malignancy. And so this should start to trigger discussions about whether we want to biopsy it, or maybe we could do further investigations with non-invasive measures such as PET scan. And so I'm going to switch gears and kind of present another patient just to highlight the different things that we can find about lung nodules. So this is a 65-year-old male who presented with abdominal pain and gets a CT scan of the abdomen pelvis. And then they cut the bottom part when on the bottom part of the lungs, they noted that there was a incidental lung nodule in the left lower lobe. So some more definitions. Flagellum Society defines a lung nodule on CT scan. They define them as round or irregular. They define them as well or poorly defined, and they have to be up to 3 centimeters. Anything greater than 3 centimeters is considered a lung mass. And it's not to say that you have to find them on CT scans. You can see them on nodules, of course, but they're usually more readily detected on the CT scan. And so not all lung nodules, of course, are cancerous. In fact, the majority of lung nodules are benign. In the original NLST trial, there was a false positive rate of the way they described false positive, meaning that there was no cancer detected, but there was a nodule, was over 95%. So they found that over 95% of the nodules that they detected on their screening were not malignant, which is good news for most patients that present with a lung nodule. So here are a couple things that I listed that can cause lung nodules. So infections, stuff like TB, fungal, lung abscess, round pneumonia, such as inflammatory diseases. GPA or vasculitides, sarcoidosis can cause almost anything in the lung. And then some congenital defects can also cause some lung nodules, such as like a pulmonary AVM. On CT scans, you can see certain characteristics that like radiologists will tend to call out. They may see, like in a pulmonary AVM, they may see that the nodule is right adjacent to a blood vessel, right? That makes sense because it's the mixing of the arteria and venous. Congenitally, like defect. So then it grows from like a venous, or sorry, grows from a vascular structure. And then in certain infections, there's like certain characteristics like ground glass or maybe like tree and bud nodularities. There's certain things that may um, point to more infectious rather than like a malignant cause. And then on a lung nodule, you have to describe whether it's solid or subsolid, which kind of also goes into the next part of risks. A solid means that it's completely obscuring the parenchyma behind it. So such as in this picture, I don't know if you can see my mouse, but on the picture on the right, you can't really see the lung parenchyma behind the nodule. And then whereas the subsolid parts, you can see the lung parenchyma behind, somewhat obscured, but not fully obscured. Um, and then the subsolid nodules are more common than subsolid nodules. But the subsolid nodules generally require a little bit more screening to make sure that they're not malignant. So, and then an incidental lung nodule, which is what we have for this gentleman, is a nodule found when you're trying to image for something else. So, for instance, he had abdominal pain and he got a CT scan of his abdomen pelvis, but it just happened to catch his lungs and showed this nodule. So with the increase in CT scans, this was 20 years ago, but with the increase in CT scanning done, there was a much greater detection of lung nodules and incidental lung nodules, and so it's very common to find lung nodules in on a routine workup. And so we needed a way to really see, are they all malignant? Are they all having should they all be biopsied? How long should we follow them? And then how common is like malignancy, for instance? So here's uh, a review of CT scans done in a 6-year period by Dr. Gold and his team over at actually in Kaiser down here. And so in the Kaiser Health System from the years of 2006 to 2012, over 400,000 CT scans were performed for over 200,000 adults. And they were looking for lung nodules anywhere from size 4 to 30. And then they would like routinely follow them up with CT scans also if they needed to, if they were getting bigger, for instance. And so the nodule also, or they're able to note that the identification of nodules increased over time from the 6 years, from about 4 to over to the mid sixes. Uh, Good news for us though is that the rate of lung cancer detection remained the same, even though the number of nodules we were diagnosing had almost doubled. And so, again, another very busy slide with data, but the short of it is that my bullet points, the number of chest CT scans performed per year increased from 46,000 to 71,000, so almost doubled. And then the number of unique patients who had at least one positive CT scan qualifying for a lung nodule increased from 8,000 to 17,000. So this really did double over the 6 years. This is just saying that they detected more nodules, and then those that had larger nodules, they found more of them as well. And then this is my last point. Among patients who had at least one positive CT scan from that time period, only 3,000 of them received a lung cancer diagnosis. This makes up only 5% of patients. And then this is 5% of all patients with a qualifying lung nodule, which is only about 0.1% of all adult members. So this is just more good information that the majority of the nodules that we're going to come across incidentally are going to be benign in nature. Let me see, did I skip anything? Okay, so he presents in our clinic now with like all this new information, and he's wondering what to do. So you get more history. He's a non-smoker, no family history of cancers. He was born in Mexico. He immigrated here 40 years ago, and now resides in Southern California. And so you'll find that incidental lung nodules also correlate very much with kind of where you're from, your history. If you started to do significantly more CT scans in, say, the Midwest or in the Mississippi, like Ohio River region, you'll find that incidental nodules are more maybe due to like histoplasmosis. Whereas if you do like the CT scans here in Southern California, maybe some of those are more likely to be due to like tuberculosis. So a lot of these incidental lung nodules can be kind of correlated with where patients come from or where they're endemic to it, and helps to kind of guide where your differential should be. So going back to what do we do with all these different incidental lung nodules? So again, from the Fleischer Society back in 2017, they came up with basically kind of like a chart or a flow sheet on what they feel like would be the right standard for doctors, for patients, and for radiologists to kind of call what is a standard process basically. And so they created this, which I'm sure most of you remember this chart from like everywhere, I guess. So I remember it from medicine clinic, and kind of looking at these over and kind of putting patients into like which category. So they have a part for solid nodules. So this is my solid nodule part. Um, the main risk factor in general is if they're smokers. I think that then changes from low risk to high risk. And then family history of cancers also kind of can change your low risk to high risk. And then based off of that, you put them into a different, how big is the size of the nodule, which then you can get a recommendation for a follow-up. And so again, these are for incidental nodules of a particular age of patients greater than 35, and they don't have to have, and they have to have no history of lung cancer or cancer in that, for that matter, to qualify for these recommendations. And so, in general, incidental lung nodules that are less than 6 millimeters do not really need any sort of follow-up. I'll go into a little bit more with my next, or in about a couple slides on why that is. And then if they're in the intermediate range, which is like 6 to 8 millimeters, then you can consider doing it. If they're high risk, then it's a recommendation that they probably should get it. And then if they're low risk, then just kind of consider doing it. And then anything greater than 8 millimeters should get a follow-up, and even consider for PET-CT, or maybe even consider biopsying upfront. So this is for subsolid nodules. So subsolid nodules are ground glass. They don't obscure the parenchyma. There's a thought that maybe like within the alveolar tissue that it's being filled with, or being replaced by like maybe a slow growing malignancy. Infections can cause subsolid nodules as well. So these are generally slow growing in nature, and so then in that case, the follow-up is usually a little bit longer. The solid nodules you can do for about anywhere for, sometimes you can just completely ignore them or don't have to have any sort of follow-up. Whereas for subsolid nodules, there's a recommendation that will go up to even 5 years of just like routine CT scans, depending on the size and depending on the risk. So given high-risk patient with a subsolid nodule, usually intervals of 3 to 6 months, and then of course if there's the stability, you can space those out, but they should be continued to be screened every like year at least for up to 5 years. So, and then yeah, I think that's all I got for that. Okay, so within that original Gold study of when they screened for how frequently lung nodules are being detected in CT scans, they were able to kind of chart out what kind of size nodules they were getting, and then what ends up being cancer overall. So I choose this. I'm going to mark off this line right here, up to 6 millimeters. The majority of the lung nodules that they found. So 1,200, 1,400, 900. The majority of them, and in less than 4 millimeters, even 4,000, were less than 6 millimeters, or 6 millimeters and less, basically. And you can see that the percentage of lung cancer like almost quadruples here from 6 to 7 millimeters. So generally, anything 6 millimeters or less than 6 millimeters is really unlikely to be lung cancer, given these kind of like the historical findings that we've seen. And so I think that's why the societies and the different groups chose like the 6 millimeter as a cutoff. But I would like to say that it's a scary thought too, that there are non-zero lung cancers, or there's a non-0% chance of finding lung cancers in these sub 4 millimeter nodules. So it is scary, I guess, but it's the idea that we are doing more screening, and the other side of it is that once you've found a lung nodule, most often than not, you're probably going to get at least definitely in a screen, you're going to continue annual screening for them. And so this wouldn't work for incidental lung nodules, because if they're less than 4, you probably just forget about it. But if they were smoking and they have like this kind of this risk factor, you're going to get follow-up. You're going to get a follow annual screen, so you can see if these less than 4 grow year after year, and then maybe they may warrant that they get a biopsy and a diagnosis earlier, potentially. What am I trying to say here? I think, okay, so when we think about our incidental patient who had a 10 millimeter nodule, he falls to this, right? He's a low risk. So we can consider getting a PET scan, which is my way of segueing into a PET scan, basically. Before I get there, though, once you have a incidental lung nodule, the three groups or three buckets that we tend to put them in is either careful observation of the lung nodule, which kind of falls into the like the Fleischner. You can continue to like routinely follow them up, or if they're high risk enough, if they have a like 2 centimeter 2 centimeter nodule, and they're an avid smoker, and maybe they have a lung, the family history of lung cancer. And let's say you were to get a PET scan and it's positive anyways, uh, or sorry, it's negative. For whatever it's worth, it's negative. Like it doesn't change your pre-probability risk or pre-risk assessment of this patient having maybe a big chance of having lung cancer. And so uh, I tried to show in the beginning that like if you can diagnose lung cancer earlier, the survival is significantly better than like a stage 3 or stage 4. And so these patients that if you have the high risk probability and they're good surgical candidates, then maybe they should just go directly to surgery and have it cut out, and which would be both diagnostic and curative. And so, but the bigger group would be this third group, the ones that you have this kind of middle of the range, unclear. They maybe have like a remote smoking history, or maybe they have a remote cancer history, but they're non-smokers, and the size of the lung nodules maybe about a centimeter. And so you can maybe then consider getting like a PET scan here, and that may push you one way or the other. I think once you're in this middle area, it's to really determine whether you and the patient are going to feel comfortable doing either this bucket, the first bucket, which is the careful observation, or are you going to push them into the surgical kind of domain, basically? And so, with all the things that I've already mentioned, the majority of our incidental lung nodules are benign, 95% roughly, right, from a previous study. So it's a big range that you're going to find a lot of these nodules in between the probability of having a cancer. In fact, this is where like you look at a risk assessment, such as like a Mayo calculator, or I'll talk a little bit more about these different calculators. The probable benign side is up to like 5%. And then the high risk ones are like over 70%. And then you have this huge gap from like 5% to 70% that fall in this intermediate category that you're really trying to figure out what's the next best step for the patient. So, oops. Okay. So what about some guidelines? So this is from ACCP or CHEST. It basically kind of followed the same things that I just mentioned. They use the size cutoff, and then they also the clinical judgment and the kind of the patient's history to suggest like to getting a pretest probability of malignancy, and then using that as where you're going to go to do next. So I honed in on the middle bucket here because in a patient with 8 millimeters, then and a pre-pretest probability of you can start to use like the calculators, which I'll talk to in the next slide. You can get a PET scan because again, this will kind of it's very avid PET scan. Maybe that'll like push you more and the surgeons more to wanting to like do resection or maybe getting a biopsy. And then also, kind of when they have a high pretest probability, the a PET scan is not really going to help you because if you're already concerned, and I might have said this already, if you're already concerned enough, then even if the PET is negative, you wouldn't just leave it alone. You couldn't just really ignore it. You should at least maybe talk to the surgeon about what can do next. And so we have calculators and we have like prediction models for when a lung nodule is detected. The Swinson model is the Mayo model. So it's developed in the Mayo Clinic. This is the one that most people are probably familiar with on like the lung nodule calculators. What these models do is they have a slight difference in how they were correlated. And so the Mayo model was just a basis of the nodule characteristics, the sizing, speculations, where it is, the smoking history, and also I believe what was the last one? I think that's it. The Herder model, I believe, just takes into adding a PET scan to the Mayo model, like whether they got a PET scan or not. The Brock model actually uses the screeners. So these are for like incidental, the top two, whereas the Brock model is they took the different patients that got low-dose CT screening, and then they were able to kind of see later on whether they got biopsied or not based off the characteristics of the nodule. They can kind of give you an idea of how risky they were prior to the diagnosis. And then the VA model is just that they used the different VA patients. And so if you were to have a patient come into your clinic, maybe you might consider a different model depending on their history, right? So if you have a VA patient, you may choose to use the VA calculator, or if you have a PET scan, then you may choose to use like the Herder model, for instance. Or if you had someone that is a screen, then you may want to try and use the Brock model. But these are all just going to give you estimates that'll put you back into this kind of predicament of choosing whether we're going to get we're going to continue to do serial monitoring, or we're going to do a PET, or we're going to refer them to surgery, right? Or sorry, the middle one will probably be biopsy at this point, especially if you already got the PET scan. So a little bit about PET scan. So can they non-invasively diagnose cancer? So no, PET scans are images of deoxyglucose. It's a radiolabeled glucose is what I tell people. And it goes to metabolically active cells in the body. And so your brain will always light up, your kidneys are always generally going to light up, and your parts of the heart will always light up. And so that's why you always have to get like an MRI brain to stage lung cancer, because the PET's not super helpful in that. It'll just kind of always be active, right? And then PET scans aren't great at detecting small nodules because there's generally not a lot of activity, and they're not great for ground glass because there's also not a lot of tissue. And so, in general, we try not to get PET scans for anything less than 8 millimeters. You can, and sometimes there's like a faint uptake, but it doesn't. It may not help you with what you want to do next for the patient. So, let's see. This is a meta-analysis that reviewed 70 studies utilizing PET scan in endemic and non-endemic centers. Another 8,000 nodules seen, pooled cancer prevalence 60%. This is the interesting part, was that 10 out of the 70 studies reported endemic lung disease. So these are like the centers that have a lot of histoplasmosis or other blastomycoses and cryptococcus or other sort of fungal endemic infections, because those will be PET avid too. And the pooled sensitivity and specificity of the meta-analysis was 90% and 75%. And so what they found was that the estimate of like when you break it down into like the different regions, endemic disease was noted to have less findings of lung cancer than compared with non-endemic regions, which makes sense. So when you have a endemic region and you get a PET scan, you can't necessarily say that it's like concerning for lung cancer. In fact, you should probably more be thinking about the endemic lung disease, such as the fungal infections that I mentioned. So, all right, I think I'm done with the lung nodule like history and the workup and stuff like that. So let's talk about some fun things. So you've decided now like to get a biopsy because we don't have enough information. The PET scan is plus minus positive. They're sort of in that intermediate risk still. And so the tissue is the issue is like the common phrase for most the malignancy workup. And so there's a lot of different ways of going about getting a lung biopsy nowadays. The picture on the left is a transthoracic CT-guided needle biopsy. The middle one is a bronchoscopic forceps biopsy. And then the right is a surgical lung biopsy, usually done under VATS. So I'm not a surgeon, so this is kind of what I saw for guidelines in terms of when would they suggest like a surgical biopsy. So again, when the clinical probability is very high, greater than 65, 70% on either your clinical gestalt or your calculators, or when the nodule is intensely hypermetabolic, but they don't give you like a certain SUV cutoff or anything like that. Just again, it kind of fits into like your overall feeling of like whether the pretest is high or not. And then if you had like a non-surgical biopsy done that showed maybe a little bit atypical cells but didn't diagnose it, or maybe you missed or something like that. So, or if the patient just prefers to have like upfront knowing that they can get maybe curative intent and they're a good surgical candidate and they don't understand the risks of the surgery itself. And so, an individual with solid indeterminate nodule measuring greater than 8 millimeters in diameter who chooses a surgical diagnosis, we recommend a thoracoscopy to obtain a diagnostic wedge resection. So surgeons will go in and they'll cut a part out where the nodule is. This is not helpful yet. And then they can send it to pathology, they can look under frozen and determine whether it's truly malignant or not. At that time, if it is, then they can convert the wedge to a lobectomy or a segmentectomy to get like basically a curative intent. There's a little bit of more nuances to that, but I'll actually get to that at the end. And so sometimes these nodules are pretty small or they're pretty central in the lung. And the way they do these VATS procedures is that they have to isolate the lung that's got the disease in it and deflate it, and then they can enter in with their VATS, and then they have to try and find it. But all they can see is the pictures like A, B, C, D, for instance, right? Like, or sorry, A, B inside the chest. Like you don't know in the lung where exactly it is. So there's different ways to help the surgeon to localize it. So on the right side, we can insert these hooks, such as seen in A and B on the left side, and you can put it right next to the nodule itself. So then when the surgeon goes in, they know to at least cut as deep as where the hook is to make sure that they get the nodule. And they can't feel it. Usually sometimes it's like tactile, but it's not as great, especially if it's a ground glass or if it's very deep into the lung. So other ways that we can help the surgeons is that as interventional pulmonologists or radiologists can actually inject dye next to the area of the nodule, and they can then see it light up either with directly, or there's actually cameras that highlight certain chemicals and fluorescent dyes that they can then make sure to cut out itself. So uh, this was a very old study that's just basically showing kind of what is the yield for transthoracic needle biopsies. Transthoracic needle biopsy is a very good study to do. As you can see, its sensitivity is 89%, specificity is 90%. There are higher complications. You're putting a needle and you're disrupting the pleura on both ends. So there's a higher chance of pneumothorax and there's a higher chance of bleeding, just kind of given certain locations. But it does result in good yields of diagnoses. So there's a couple of ways, like it's not, obviously the bigger the size of the nodule, the easier it is. But they've shown studies that they can do up to even smaller than a centimeter that they can biopsy, and still get really good yield on their results. So let's see, what did I want to show here? Oh, the main risk of developing or doing a transthoracic needle biopsy is pneumothorax, because as you can see on the picture on the CT scan, you can see that it has to disrupt the parietal and then also go through the visceral pleura. So then by disrupting the two layers, you have the risk of developing a pneumothorax like iatrogenically. This is up to 15%. I think most studies will quote 15 to 20%. The risk of bleeding is low. There's not that many blood vessels kind of at the edge of the lung, so up to like 1%. And so this was a huge study, about 16,000 patients. So if you really think about 15% of 16,000, oh man, I have to 2,380 patients who got a pneumothorax, and they said that about 1,000 of those patients needed a chest tube. So if I'm being overestimation, 1 in 5 patients who get a CT guided biopsy will get a pneumothorax, and then a third of those will need a chest tube. So it can be pretty devastating for patients to have to then get admitted and have a chest tube workup. So it's not necessarily a super benign procedure, but it is fairly helpful, especially in trying to get these lung cancer diagnoses early. So the other side of it is when you're comparing a CT guided biopsy to, say, a bronchoscopic biopsy, we do EBUS staging or linear EBUS staging of the mediastinum. So if this turns out to be malignant, for instance, like if a CT guided biopsy gets a diagnosis of lung cancer, sometimes the surgeons may want to make sure that there's no spread to the lymph nodes. And so then they would ask us to get endobronchial ultrasound and biopsy the lymph nodes inside the chest. So you can save the patient 2 procedures or 1 procedure by, if we did the procedure robotically and endobronchially and then do the staging right after, rather than sending them to the CT guided biopsy and then to the pulmonologist, for instance. So kind of takes me to my next point. This is a topic that I'm pretty excited about. It's a growing field. There's a lot of different modalities, and we're getting better, I guess, is the best thing to say. And so before we used to try to biopsy irregularities on CT scan and with the use of like fluoroscopy. But as the years have been going on, we developed new tools to help us localize the nodule in a 3-dimensional, air sac, right? So before, it's a 2D fluoroscopy that you can put a bronchoscopy down and then you use your tools to try and biopsy maybe an opaque region. Now we have radial ultrasound, which it's a little catheter that it's not a catheter, sorry. It's basically a tube that spins like this, and then you can detect the ultrasound images. It's not able to localize. So for instance, picture A, that means that the ultrasound is like right in the middle of the what is probably a nodule. Whereas like for picture B, it's half on and half off, which means that the nodule is probably not in the airway, and the radial ultrasound is up against that airway that sees it, but the other half of the radial ultrasound is just in the airway, and that's why you get this air artifact on the like bottom right side of it. And then C is just like if it's in a airway itself without any sort of detection of a nodule. But when you get a picture like B, it's not that the nodule is up and to the left. You don't know where it is in three-dimensional space because where your probe could be like flipped around upside down and stuff like that. So it's helpful at detecting roughly where the nodule would be in space, but not exactly a localizer. So then they developed something called Super D, or they used the electromagnetic bronchoscopy. Sorry, Super D is a brand. It's like saying Kleenex, I guess. They came up with electromagnetic navigational bronchoscopy. What they do is man, can you guys see my pointer? Maybe? No?
No.
No. Okay, let me see. Is there a pointer on this thing?
I was able to see that.
I saw it.
My little draw. Okay,
I'm
okay.
just blind.
Sorry. Okay, here, let me try and draw. So they
Yeah, we can see that.
Oh, there we go.
a field generator, right? And this field generator creates an electromagnetic field. Imagine like there's like electrical field now where the patient's chest is in. And then at the edge of the camera, there's a little probe that the field will pick up the probe and then will kind of, know in three-dimensional space where you are. So then you get a CT scan for the patient, and then you can drive based off the CT scan to where like this new electrical field is and go to the nodule itself. So this was created maybe about like 15 years ago and was originally used to navigate to the nodules because, like I said, once you're down here doing this, you have no idea in space where you are. It's a two-dimensional picture. You could be going into the nodule, or you could kind of be going like this way and you would have no idea. And so this helps a little bit to drive and navigate to like a space that you're more comfortable with, but it doesn't help with the you then use the radial ultrasound and you can kind of like find it a little bit better and fine tune, but it still doesn't still has a lot of problems. So when they did the original Super D studies, the yield was anywhere from like 50% to 70%, which like if you compare that to transthoracic needle biopsy, that's 90 percentile, right? So it's not the greatest tool. And so we had to come up with more modalities, and that's what brought us to a robotic assisted bronchoscopy, which is on the bottom right here. And I'll talk a little bit more about that on the next slide. Sorry, just kidding. I will talk about it eventually. Can I get rid of all the drawings? Okay. So to give you a little bit more history, when we did conventional bronchoscopy, we would do a lot of different tools. Washings is spelled wrong. You can utilize biopsy forceps, like I mentioned. You can do needle biopsies, like FNA of the lung nodules. You can do BALs and washings, where you instill sterile saline and then you aspirate it. Maybe it like washes some of the tumor cells, and then you pick it up. And then the diagnostic reporting for this was around 65 to 88%. But this is pretty high for what is like generally thought of to be a low yield procedure. Like the bronchoscopy itself needs a lot of work. And so when they reported this, the idea is that most likely was that the masses that they were finding were very centrally located, so you didn't have to go very far into the lung, like the periphery, for instance, where CT guided biopsies are better. And it was probably also like very big nodules, or very big nodules, so where it would be easier to kind of find them or get to them without any issue. And then the rate of pneumothorax and pulmonary hemorrhage were very low, right? You're not disturbing the pleural lining, or you're not really getting close to sort of like the blood vessels, because you're seeing where you're going to go relatively, at least on the ultrasounds and stuff. So, or on the fluoro. Let me make sure. This is the radial ultrasound. Like I mentioned, you can get something called a concentric view, where the radial ultrasound goes down the airway here. It goes down the airway like this, And then if the nodule is around the airway, then you'll get this picture right here, kind of like this. But if there's a nodule like this, kind of sitting on the airway, the radio will only pick up half, right? It can only pick up the half. And you know then where the radial ultrasound is to your bronchoscope and then on fluoroscopy, and it kind of just pinpoints a little bit better where the nodule is. So this helps with really fine tuning the biopsies. And in fact, there was a lot of studies on whether this was if you can get this picture of concentric view where the tumor is kind of like all around, it increases your yield from 70%, from 50% to 70%. So almost when you can't find a concentric view and you go and try and biopsy, it's 50-50. Like this showed that like you're basically biopsying in the dark and you had like a 50-50 chance of getting a diagnosis. So imagine going to a patient and saying, hey, I can do this procedure for you, and there's 50% of the time we get a negative result. I don't know whether it's I missed it or I actually got it or not, right? And so it's very like it's not a great it wasn't a very great procedure to do with just that way, unless you were able to get this concentric view, and in that case it increased your yields significantly. And so we came up with better modalities. Again, electromagnetic navigation helps. It can get you closer to the lesion. It can get you farther down into the airway without driving, like you don't know where left and right is, and you don't know where up and down is once you get past like the 6th or 7th generation of the airways. And so this navigation can then kind of using right here, I'm sorry, I can't see this drawing right here, but you can literally follow a GPS system that drives you down to the distal part of the lung itself. So there was a couple different studies that looked into electromagnetic bronchoscopy, the Acquire registry. So this is 15 centers. They did 312 bronchoscopies with the Super D, basically, and they did a bunch of different ones. They had like just regular bronchoscopy. They had the electromagnetic bronchoscopy alone. They used both electromagnetic bronchoscopy plus the endobronchial ultrasound, and they didn't really show that it changed too much when you use this system plus the other systems. The only thing that they were able to see that was a big difference was whether you were able to get like concentric or eccentric views with the radial ultrasound, which was demonstrated in another study. And there was another study that came out after the Acquire that showed very high yields using the electromagnetic navigation system. However, again, these were thought to be a little bit inflated. Their sensitivity was significantly lower than their specificity and their positive predictive value, and so there's a lot of nuance to how they reported it, like what was a true positive finding and what was a true negative finding, and so it led to actually like stricter criterias even. But a lot of the study was to show that also there was no the risk of the complications from doing the procedure were a lot lower than if you had a transthoracic needle biopsy done. So. Okay, getting to what I'm most wanted to talk about. So now we have, and I think most systems nowadays, or most centers nowadays, don't use the like a Super D or electromagnetic system. There's a lot of complications with just kind of you holding your scope. You have, you have too much movement. A robot can then hold your bronchoscope and go in and out of the patient with complete stability. It won't move. It won't get tired of holding a certain position, and then it stays stable when you're doing your biopsies. Can you imagine if you're holding your bronchoscope but you insert a tool and your hand slips and then you don't know where your bronch goes, right? So there's a lot of different things that can potentially decrease your yield for your bronchoscopies. So there's 3 systems on the market right now. The left one is the Monarch robot created by Johnson & Johnson. This was the first one that came out back in 2016, I believe. And then 2019, sorry. This is the first one that came out to market. The next one was the Ion, which came out a little bit after that, which is the system that we actually have now at USC. And then lastly, the most recent system that came out was this Galaxy system. The Monarch and the Galaxy both use electromagnetic bronchoscopy, so they use that same thing as the Super D. They generate a field, and then at the end of their bronchoscopes, they have the probe that can be detected by the field. Whereas the Ion robot has shape sensing modality. So what it means is that the catheter and how it bends in space, it lets the robot know where in the body it is, and it's kind of its own proprietary like technology that allows it to One, you don't need an electromagnetic field, which can be disrupted by like your fluoro machine or like electronic systems in the room with you, and then you lose your navigation. Or it's also a smaller catheter, which I'll show you right here, the comparisons. It's a smaller catheter, and so it can get to like farther parts of the lung without issues of like tearing the airways or damaging the lung itself. So the Monarch outer sheath is it has two sheaths, an outer sheath and an inner sheath, inner scope. They can move simultaneously from one another, but the idea is that it's a pretty big camera, so to get to like the smaller parts of the lung is a little bit more difficult. The inner scope is a little bit smaller, so it could go, but it's still significantly bigger than the other two. The Ion shape sensing one is significantly smaller at 3.5, so about half of the outer sheath of the Monarch, and then it's still smaller than the Galaxy at 4 millimeters as well. And then, like I mentioned, Monarch and Galaxy both used what's the electromagnetic field, and then Ion uses its own shape sensing proprietary information. And so I've had a chance to use all three of them, and anecdotally, I've been getting more yields the more robots I do, which makes sense, right? Like there's like a learning curve. So whether it's I've gone from Monarch to Galaxy to Ion now, and whether it's because I'm getting better at the robot or maybe the robot is superior, it's all kind of like anecdotal. Are there studies to try to like show the comparisons between the two? So this is the feasibility study first. In short, due to time, yes, it works. Robots work and are able to get down and localize lesions or nodules and able to get to biopsies. Median size about 2 centimeters. The eBus was able to localize them. You were able to see them on fluoro, you were able to kind of get down there with navigation fairly quickly, and then very low complications. So feasibility, yes, it works. Now, when you compare electromagnetic versus shape sensing, there's never going to be like a direct head-to-head, right? The two companies probably don't want to do that. And then these are like multi-million-dollar machines, like with upkeep and upfront costs. So the most centers aren't going to be able to buy both of them. But this study was in chest and compared the shape sensing Ion versus it's called the tomosynthesis Galaxy robot, and they had similar comparisons of nodules in terms of how many they did. So the shape sensing did 143, and the Galaxy did 100, almost 200. Diagnostic yields were pretty similar between the two. And then the size of the two nodules were roughly the same too, and then the complications were about the same. So I think every comparative study that I've been kind of like looking at between the different robots, when you look at diagnostic yields and when you look at complication rates, they're all roughly about the same so far. There are more things coming out that will kind of change that, and probably as you find more centers being able to do actually comparison studies, we may find that one robot is slightly better, and right now though it's more of like a preference, like a physician preference. So what about robot versus transthoracic needle biopsies? This is a study from respirology done from 2019 to 2021. 113 robot-assisted bronchoscopies versus 112 transthoracic biopsies. And here's the yields for them, 87 for the robot and 88 for the transthoracic. So similar sensitivity, similar yields, specificities 100% for both, but a significantly higher complication rate in transthoracic needle biopsy, 17% versus almost quadruple the rate of complication rates, including like pneumothorax and hemorrhage. And so again, to reiterate, you're increasing the potential rate for complications just given the nature of how a transthoracic needle biopsy is done. And then you may also need a second procedure, such as an EBUS, to do the staging if you were to go the transthoracic needle route rather than doing a robot followed by an EBUS under the same general anesthesia event. So if I had to argue one or the other, of course, I would argue for the robot, right? Okay, so some newer technology that's still coming out and we are implementing. This is a little bit of an older technology. This is called a cryoprobe, and we do cryobiopsies now. And so it's a probe. It's a probe that has a little tip at the end that can freeze down to negative 80 degrees within like seconds, and with a step of a pedal, of course. And so it creates this little ice ball at the edge of it, and then that freezes to the lung tissue, and you can grow it, so on and so forth. And then you literally yank out the tissue, and it gives you like a nice big circumferential piece. And so then when you get these signals like the EBUS, the radial EBUS signals of like the tumor is like on top, but it's not a full circumferential. If you have a radial probe, you can grab like that part because you know it's going to be touching circumferentially. And so this has been showing to like improve diagnostic yields just by the nature of the way it biopsies rather than like a needle that has to kind of like sit, into the lesion, right? So the thing on the left here is a Siemens fluoro arm. It's a C arm basically, but it has the ability to spin 360 degrees and create a cone beam picture. And so we can actually utilize, this is actually integrated now with the Ion machine platform, that you can go down into the lungs, and then you can get to the point where you're about to biopsy, maybe even put your tool out, and then with the tool out in hopefully the nodule or where you think the nodule is, you can get a CT scan basically right then and there and see that your nodule is in your tool is in the nodule, and do your biopsies that way. And so this has been, Stanford does a lot of these, and they've reported like that their yields have gone up by 10%. So without the C-arm, I think they were getting like 80% or so like that. With the C-arm, with the cone beam CT, they get up to like mid 90s is what they're reporting. And then lastly, I've been talking about a lot about like diagnoses and kind of finding lung nodules or what to do with lung nodules. But the future is actually, once you've got a diagnosis of lung cancer, we want to be able to treat them maybe all in one event. So ablation is coming. This isn't a good picture of ablation. This is just the needle going out into the lung. But this is what I wanted to highlight, is that you could potentially ablate that area and destroy the lung cancer and treat their like stage 1 lung cancer all in one diagnosis, anesthesia event, treatment, right? So that's part of the future kind of planning. So, all right. So let's see. Lung cancer screening patient undergoes a PET scan that showed avidity. So that was the first case, the very first case that I presented. Mediastinal lymph nodes were not positive. Transthoracic needle biopsy, so CT guided, showed adenocarcinoma. He underwent that and lymph node dissection with curative intent, and was cured. So that's the first case kind of in resolution. The incidental lung nodule undergoes a PET CT with increased avidity and some mediastinal avidity. A robot-assisted bronchoscopy with conventional EBUS is performed and found to have cocci. He's referred to ID, he gets fluconazole, and he gets treated. This is a little like flow sheet that I kind of made for myself just in this last, like just when dealing with lung cancer or lung nodules, sorry. Lung nodule less than 8 millimeters. If found on low dose screening, you can follow lung RAS. If incidentally found, follow Fleischner's. And then same with the sizing. If it's a lung nodule that's 8 to 30 millimeters, then you can do a lung nodule risk calculator or your own clinical gestalt for a risk malignancy. Then it puts them into like the low risk, intermediate risk, or high risk. For low risk, you just do serial monitoring. For high risk, you'll talk to the surgeons and see whether they would be a good surgery candidate for just resection. In the intermediate risk people, you can start with a non-invasive PET CT scan or some biomarkers. And then you can even consider tissue evaluation. I think before we would do more PET scans because the tissue evaluation would get yields of 60 to 70%, and those weren't great yields. So now that we're able to increase our diagnostic yields, I think we're moving more and more towards transthoracic needle biopsy and robot-assisted bronchoscopies faster and earlier than when we were before. And I'm sure that's going to be shown in the oncoming years. I was told to talk about a palliative intent. So I don't think there's much palliation for lung nodules, unfortunately. So I took it liberally and I extended to what lung nodules could be, and could be metastasis from lung cancer. And if you get metastasis to the pleura, then you can develop malignant pleural effusions. And so one of the main things that we also do at USC for these recurrent and malignant pleural effusions is something called the Pleurex, or an indwelling pleural catheter. This is a catheter that runs under the skin and then into the chest, and the tube stays in like under the on top of the diaphragm and in that pleural fluid, and then the patients can drain them at home. It's technically made so that the patient can do it themselves. It's a pretty simple thing. You literally there's like this one tube that goes into like a hole, and then you just click the vacuum down and then it drains. The problem with all that though is not the actual drainage, it's when you try to apply the dressing stuff all over again. I think you need like a third hand to hold things while you put the dressing down. So it is made so that you can do it yourself, but in general, it usually needs like another person. And so not only is it palliating in that they don't have to come back and get like thoracentesis and stuff, but it's actually also it could potentially pleurodesis, a mechanical pleurodesis on the inside of the lungs. So the more they drain it, the more that the tube will kind of like mechanically rub the two pleural linings of the lung and then induce inflammation. And then that can cause pleurodesis where it kind of, it removes that potential space. And then fluid may not come back. And so then the pleurax drain could come out. So it's both palliating in that, yeah, they don't have to come to the hospital, but I think it's also that treating potentially the recurrence. And so pleurax catheters usually last, I would say, anywhere from, I think, 40 to 80 weeks is what the usual studies have shown. If they drain it daily, that number can actually come down, like they more towards like the 40 to 50 range. If they drain it every other day, which was like the original intent, it's usually in like the 50 to 70 range. So another thing that can happen with these lung nodules is they can turn into big eroding tumors. So this is a patient's left main stem, right main stem. If you go down the left main stem, you see this big mass obstructing the left main stem here. And yeah, you can't, they basically lost their lung on the left side. And so what we can do for, palliative efforts is we can debulk this tumor and then leave a stent behind that then allows their left lung to aerate. And so I thank you guys so much. I think there's been a lot of patients that we've brought from outside hospitals to do this procedure for, and it's all just so we could, hopefully get them breathing better to get them to their next modality of treatment. Like this isn't technically curing anything, but it does hopefully get them to the next step of their oncological treatment. Lastly, for palliation, I'm pretty sure most people remember this study, early palliative. This was back in, I think, 2010, 2011, maybe even. But early palliative care leads to, actually they showed a lot of different things, but I think one of the main things was that the median survival increased in those that got early palliative care rather than the cohort that did not. So, and then I have my little question here. I took this from Mixap. So 72-year-old woman evaluated during a routine visit, 30-pack year history, quit 5 years ago, history of mild COPD and breast cancer, diagnosed 15 years ago, currently in remission, and a chest radiograph from 5 years ago showed no signs of disease recurrence. She is on albuterol and Spiriva. On physical exam, everything's pretty normal, except for a prolonged expiration, diminished breath sounds throughout. Breast exam is unremarkable. Screening low-dose CT scan shows a peripheral 9 millimeters solid pulmonary nodule in the left upper lobe with an emphysema, but no mediastinal or hilar lymphadenopathy and no pleural effusion. A PET scan using FDG is performed and the nodule is intensely hypermetabolic. There's no evidence of distance uptake. Which of the following is the most appropriate management? Bronchial biopsy, serial chest CT scans, surgical wedge resection, transthoracic needle aspiration. So, this is what you think this is a low risk patient. This is a high risk patient. These are the intermediate patients. I think by the history, 30-pack year history, only quit 5 years ago, a relatively large nodule and positive FDG. As well as a history of lung cancer, or sorry, not lung cancer, but breast cancer, right? Puts her probably in the high risk. And so that's why the answer is C. If let's say you went with A or D and you tried to biopsy it. If you get a negative biopsy, would you believe it? Like, would you say like, oh, she doesn't have cancer? I think you would still ask the surgeons to like weigh in and see like, should we just cut it out, right? Because she's so high risk that like I don't think you would feel comfortable leaving just alone, and that goes with the same with B. She's too high risk to just kind of get serial CT scans for. So, I think that's it. Oh yeah, I did. All right, cool. Hopefully I left enough time for questions.
Thank you so much, Dr. Lee. It is past the 1 o'clock hour, so I won't make people stay for questions. But just really quickly in the chat for you, everybody else, is that the CME credit is how to get the CME credit if you text the code, as well as how to email Brandon for the MOC credits as well. But any urgent questions from the audience? Okay. I'll let everybody go, but thank you so much, Dr. Lee. You guys have his email, so please feel free to email him if you do have any further questions. And with that, I'm gonna end it.
Thank you. Bye, everybody.
Thank you.
Bye.